Shock is basically insufficient end organ perfusion. So how do you come to a diagnosis of shock? It's a combination of vital signs, clinical parameters, and laboratory values. Vitals wise, you will find the mean BP of less than 60 millimeters of mercury. In certain places, it's been described as less than 65 millimeters of mercury. And systolic BP of less than 90 millimeters of mercury. Okay. Clinically, you might find altered mentation and decreased urine output, etc. Laboratory wise, you will find increased serum lactate, metabolic acidosis. Basically, what happens here is there is tissue hypoperfusion. When there is tissue hypoperfusion, there is organ dysfunction and later organ damage. So the goal is to reduce or reverse this phenomenon. Okay, now let's come to the types of shock. If you imagine the cardiovascular system as a series of pipes with a pump in it, now let's describe the different types of shocks. First is cardiogenic shock, which is basically a pump failure. Examples where cardiogenic shock would occur would be MI, myocarditis. The second is hypovolemic shock, wherein there is not enough blood to be pumped around. Example would be hemorrhage. The third would be distributive shock, wherein there might be enough blood or fluid to be pumped around. The heart might be fine, but the blood is distributed away from the pipes. Example for this would be septic shock or anaphylactic shock. The fourth is obstructive shock, wherein there is an obstruction in this system. Example would be pulmonary embolism. Commonly, you will find cardiogenic shock, hypovolemic shock, and septic shock, and rarely other shocks. Broadly differentiating between the different types of shocks, when confronted with the clinical picture of shock, if you can measure the cardiac output and then calculate the cardiac index, if the cardiac index is less than 2.2 liters per minute per meter square, then it is more likely to be cardiogenic shock or hypovolemic shock. Whereas if the cardiac index is normal or increased, it's more likely to be a septic shock. In the cardiogenic shock, you will find a decrease in the pulse pressure. There will obviously also be a decrease in the diastolic pressure. Clinically, patient will have cold extremities. The nail bed perfusion will be reduced, but the JVP will be raised. And auscultation wise, if you auscultate at the apex, you'll find S3, S4 gallop. If you do a chest X-ray, you'll find pulmonary edema there, and you'll find a large heart. And on an echo, you'll have the findings of a decreased ejection fraction and increased end diastolic volume. In hypovolemic shock, you'll find that pulse pressure is decreased, the diastolic pressure is also decreased, the extremities are cold, the nail bed perfusion time is also delayed. If you do a chest X-ray, you'll find that there is diminished cardiac size, and on an echo, you'll find that there is reduced end diastolic cardiac chambers. Whereas in the case of septic shock, the pulse pressure is actually increased and the diastolic pressure is very much decreased. There is a large gap between the systolic and the diastolic pressure. The peripheries sometimes may be warm, they might as well be cold, and the nail bed perfusion time is decreased. Rapid perfusion of the nail bed happens. Chest X-ray is normal. Auscultation wise, it may be normal unless there is pneumonia. Right? So is it with the chest X-ray. It may be normal unless there is pneumonia. If you do an echo, there will be a finding of hyperdynamic circulation. Sometimes there are less common causes of shock. When you find a clinical picture of shock and you find out the cardiac index, if you find that there is shock with the presence of high cardiac index of more than 3.5 to 4 liters per minute per meter square, then consider causes like Paget's disease or hyperthyroidism or AV malformations. If you find the cardiac index to be low or normal, then you look at the right atrial pressure. If the right atrial pressure is low to normal, and if you give a fluid bolus and it still doesn't respond, then you can consider causes like spinal shock, anaphylactic shock, or adrenal insufficiency. If you find that the cardiac output is low to normal with a raised right atrial pressure and it is responding to a fluid challenge, then you can think of causes like pulmonary embolism, cardiac tamponade, right ventricular infarction. The differentiation between these different types of shocks is important, as we will see subsequently. First, let's talk about hypovolemic shock. What happens in hypovolemic shock? There is decreased circulating volume of blood. Most commonly, this is because of acute hemorrhage. It can also be due to heat-related intravascular volume depletion, fluid sequestration in third spaces in the body, like in the abdomen. Based on the amount of whole blood lost, hypovolemic shock can be divided into mild, moderate, and severe hypovolemic shock. So mild hypovolemic shock is when less than 20% of the whole blood is lost. As a response to this, there is peripheral vasoconstriction in order to maintain perfusion to major organs. In moderate, wherein 20 to 40% of the whole blood is lost, here there is decreased perfusion to certain organs like the intestines, the kidney, the pancreas, etc. When more than 40% of the whole blood is lost, that is severe hypovolemic shock, then this is also called uncompensated shock, wherein the perfusion to the brain and the heart is decreased. As a result of decreased perfusion to the organs in the body, there is lactic acidosis. The severity of the lactic acidosis is said to correlate with the mortality risk. So our aim would be to increase the delivery of oxygen to the tissues back again in order to understand how to deal with this problem. Okay, let's look at some equations. The delivery of oxygen to the body is equal to cardiac output into the content of oxygen in the blood per se. If you look at the cardiac output equation, cardiac output is equal to heart rate into stroke volume. So you remember stroke volume here. And if you look at the content of oxygen in the blood, this is equal to 1.34 into the hemoglobin into the oxygen saturation plus 0.0032 into the PaO2. So in this you remember hemoglobin. So now let's go about to increase the delivery of oxygen and nutrients to the tissues. How do we do it? We have to increase the cardiac output. Preload is a predeterminant of cardiac output. So we have to increase the preload. This can be done by doing volume resuscitation. In order to deliver oxygen, you'll also require hemoglobin. So you'll have to maintain hemoglobin at an adequate rate, at an adequate concentration. Now, despite increasing the preload, if the cardiac output is not sufficient to meet the demands, you'll have to start on inotropes like dobutamin. Now let's look at how we'll go about tackling hypovolemic shock. Here is an easy algorithm to follow from Washington Manual. Suppose you come across the clinical scenario of shock with systolic BP of less than 90 millimeters of mercury, a mean arterial pressure of less than 60 millimeters of mercury, lactate more than 4 millimeters of mercury. Note here, there are two wings that are to be simultaneously done. First is the control of bleeding, and second is the establishment of vascular access and fluid resuscitation with fluid or blood. Now, looking at the control of the source of bleeding, this could be as simple as compression of visible vascular injury, or it could be opening up of the abdomen to stop internal bleeding. It could be esophageal banding or tamponade of rapid variceal bleeding. If you are able to control the bleeding through these means, then it's well and good. You can continue with the fluid resuscitation. If not, then you'll have to resort to alternate methods to control the bleeding, like vascular embolization. Okay, now let's have a look at how to fluid resuscitate. You'll have to secure two wide bore IV cannulae. It could be 16 gauge or higher, or at least one 8.5 French central vein catheter. And then we have to start the rapid fluid or blood product administration. How do we decide whether we need to give blood or not? This is based on the hemoglobin. So we'll have to measure the hemoglobin. If the hemoglobin is more than 9, then we can start off with crystalloids in the form of 0.9% NaCl or lactated Ringer solution. So in the cases of active bleeding, 2 to 4 liters of crystalloids are to be given. If the hemoglobin is less than 9, then we'll start off with RBC transfusion until the hemoglobin is more than 9. When blood is to be given, we can give up to 4 pints of O positive blood for adult males and females of non-childbearing age, or O negative blood for females of childbearing age. Later on, by the time the 4th pint has been transfused, we will have enough time to do grouping cross matching and then give the blood according to the grouping and cross matching. After we have transfused, we measure the CVP and the mean arterial pressure. That is a continuous process. We continue to measure mean arterial pressure and the central venous pressure. Now, looking at the situation, if the central venous pressure is less than 8 millimeters of mercury, then we repeat the bolus. So the boluses are given at least 20 ml per kg. Again, it is 0.9 NS or RL. Once we achieve the central venous pressure of more than 8 millimeters of mercury, there are two scenarios. One where the BP has been restored, then that means the resuscitation is complete. And the other situation is where the mean arterial pressure is less than 60. In this situation, we will have to start a vasopressor, for example, noradrenaline. When the resuscitation is complete, then we monitor the fluid responsiveness using various parameters like pulse pressure variability or IVC distension index or stroke volume index, etc., which we'll be talking about in subsequent videos in response to fluid challenges. So the idea is to avoid excessive crystalloid administration. In addition to preventing further loss of blood and giving adequate fluids, that is fluid resuscitation, we do other adjunctive measures in order to take care of the patient. These include airway management. If the patient is unconscious, we'll have to make sure that the airway is patent and the patient is breathing, that is respiration is happening. So measures to ensure that could include securing advanced airway like the endotracheal tube and mechanical ventilation. Cardiac or hemodynamic monitoring is to be done because firstly we need to monitor the vitals. Also it indicates to us the adequacy of fluid resuscitation. Because large amounts of crystalloids and PRBC is being given, there will be dilutional coagulopathy. So we need to correct the prothrombin time and the activated thromboplastin time by giving FFPs, as well as we'll have to give platelets if the platelet count is low, and we'll have to maintain the platelet count above 50,000 cells per millimeter cube. In case of diffuse or non-operable ongoing bleeding, we can try other measures like giving of activated factor 7 or antifibrinolytic agents like tranexamic acid. Because the blood contains oxalate or citrate, there can be sequestration of calcium, so we'll have to supplement calcium as well when large amounts of blood is being given, calcium chloride or as well as magnesium chloride. Because large amounts of cold crystalloids and PRBCs, if large amounts of cold crystalloids and PRBCs are given, it leads to rapid loss of body heat. So we'll have to make sure that the temperature is maintained by measures like use of blankets, using active warming with convection warmers, fluid warmers, etc. When large amounts of blood products are given, we'll have to watch out for signs of transfusion related acute lung injury, TRALI. In case of an open, contaminated or dirty wound, we'll have to give antibiotic therapy to prevent and treat bacterial infection. If it is suspected that there is adrenal injury or the patient is unable to mount an adequate stress response, then we can give corticosteroid. Thus, by taking these measures, we decrease the chances of the patient going into this trauma triad of death, as it is commonly called. This is coagulopathy, which worsens lactic acidosis, therefore causing metabolic acidosis. Metabolic acidosis causes decreased myocardial performance, and that contributes to hypothermia. Hypothermia causes coagulopathy and so worsens the coagulopathy. So this trauma triad of death increases the chances of mortality, which is to be avoided. That's it for today, guys. Have a nice day.